Hello and welcome to this Touch Talks activity. My name is Beyer-Westendorf and I'm Head of Division Thrombosis and Hemostasis and lead of the Thrombosis Research Unit at the University Hospital Carl Gustav Karus here in Dresden in Germany. Today I'll be discussing the following topics: the risk of intracranial hemorrhage or ICH in the era of DOAC or direct oral anticoagulants, the latest clinical efficacy and safety data for approved reversal strategies in patients with DOAC-related ICH, and finally, I'd like to talk about recommended guidelines on the management of DOAC-related ICH. How do we balancing the risk and benefits of anticoagulations in real world? You know that patients at thromboembolic risk are usually treated with oral or parenteral anticoagulants. And they do have a range of indications. The largest, obviously, is stroke prevention and atrial fibrillation and VTE treatment. But please also remember VTE prophylaxis in hospital after surgery, peripheral arterial embolisms, cardiac surgery, extracorporeal circulation, and many other indications where we nowadays usually refer to anticoagulations. As you know, we do have various anticoagulants available to us, and they all target different components of the coagulation cascade. When we talk about the parenteral drugs such as heparins and fondaparinux, they target antithrombin and factor 10, and by that inhibiting the thrombin activity or factor 2 activity of the coagulation cascade. When we talk about vitamin K antagonists such as warfarin, these drugs inhibit the synthesis and activation of coagulation factors in the liver, specifically coagulation factors 2, 7, 9, and 10. In contrast to that, the DOACs, direct oral anticoagulants, target one coagulation factor out of the cascade. So the factor 10A inhibitors, apixaban, edoxaban, and rivaroxaban only target activated factor 10, and by that inhibiting the synthesis of thrombin. The direct thrombin inhibitor dabigatran directly targets activated factor 2 or thrombin, by that inhibiting the clot formation ability of the coagulation cascade. DOACs have been widely approved for multiple indications. The largest indication is stroke prevention in atrial fibrillation, and in this indication, where millions of people are treated worldwide for many years, dabigatran has become approved in 2010, rivaroxaban has become approved in 2011, apixaban has become approved in 2012, and edoxaban in 2015. The other large indication, venous thromboembolism treatment, so the treatment of deep vein thrombosis and pulmonary embolism, is also a large indication for DOAC treatments, and the drugs have become approved slightly later compared to the atrial fibrillation indication. Now, when we compare warfarin and DOACs, we'll find out that DOACs have a range of benefits over vitamin K antagonists such as warfarin. From the patient's perspective, it is very clear that DOACs are more convenient. There's a fixed dosing for each indication and for each patient. And there's no need for routine anticoagulation monitoring. This is different in warfarin-treated patients, where you have to measure the INR and you adjust the dosage of warfarin according to the INR to the needs of each patient. DOACs have a very rapid onset of action and a short half-life. And this is different to warfarin, because you know that if you start a patient on warfarin, it takes days until the INR increases and the patient becomes anticoagulated. And if you stop warfarin treatment, it takes days until the effect of warfarin wears off. And finally, there are much fewer drug and drug-food interactions considered for DOAC patients compared to warfarin? Because you know that in warfarin patients, the level or the content of vitamin K in the nutrition is interfering with warfarin doses and with the stability of the INR. And again, warfarin has a lot of interaction potential with other drugs, DOACs very few. So this is the convenience part on the patient side. But there are also medically important benefits to be considered. So from a prescriber's perspective, we've learned that if you compare warfarin and DOAC treatments in atrial fibrillation trials or in VTE treatment trials, what you'll see is that the clinical effectiveness of DOACs is better compared to warfarin. For atrial fibrillation, the composite risk of stroke and systemic embolism was reduced by 15%. All-cause mortality was reduced by 14% in favor of DOAC compared to warfarin. And on the VTE population side, the risk of recurrent VTE or death was 12% lower in the DOAC-treated patients compared to warfarin-treated patients. So there are benefits on the side of convenience and benefits on the side of clinical efficacy or effectiveness. At the same time, there are benefits on the safety side. We've seen in these same trials in atrial fibrillation and VTE treatment, we've seen a reduction in major bleeding in DOAC-treated patients compared to warfarin. A relevant reduction in fatal bleeding with odds ratios of 0.3 in the VTE population and 0.55 in the atrial fibrillation population compared to warfarin. And a significant reduction in intracranial hemorrhage with odds ratios of 0.36 and 0.48 for VTE and SPAF populations, again compared to warfarin. And there's only one bleeding signal that sticks out. The risk of GI bleeding is slightly higher in DOAC-treated patients compared to warfarin-treated patients, but please keep in mind this is not transferring into more fatal bleeding, because when it comes to the signal of fatal bleeding reduction, the GI bleeding signal is contained in there as well. So there's, by numbers, slightly more GI bleeding, but the more dangerous bleedings are reduced across the board. Less major bleeding, less fatal bleeding, less ICH with DOAC. Still, even with the safest anticoagulant, there is a risk of bleeding and especially of intracranial hemorrhage, because this is the most feared complication of anticoagulation. Remember, a patient needing anticoagulation very often is an elderly patient, is a fragile, comorbid patient, and that's why we can't prevent each bleeding to occur. So the reduction in intracranial hemorrhage of DOACs compared to warfarin is important, but it's not perfect. Around 1% of DOAC-treated patients will develop an intracranial hemorrhage. This means we need to know how to handle intracranial hemorrhage in these patients, which is the first step to prevent it occurring. So what are risk factors of patients to develop intracranial hemorrhage? It's obviously older age, impaired renal function, comorbidities such as cancer or vascular disease, frailty or fragility when the patient is at risk for trauma, for falls, is important to understand as a predictive risk factor. Concomitant use of antiplatelet drugs that also cause antithrombotic activities in the coagulation cascade. And very importantly, white matter changes in cerebral imaging are a strong predictive factor for ICH risk. There are risk assessment tools such as the HAS-BLED score to predict the risk of major bleeding, to identify patients at higher risk for bleeding. But this usually should not influence the decision to use an anticoagulant, but should drive the decision which kind of anticoagulant and which dosage should be used in your specific patient. Now, unfortunately, as I said before, we can't prevent every bleeding to occur. That includes DOAC-related intracranial hemorrhage. But then we have to ask ourselves, what is the outcome of such a bleeding? How can we predict poor outcome? How can we improve poor outcome? The first answer is, if there is ICH, the risk of mortality is high. It is around 1 out of 5 patients that are not anticoagulated. It is 1 out of 4 patients that are anticoagulated with a DOAC. And it's 1 out of 3 patients in those who are anticoagulated with warfarin. So the overall mortality is high, and predictive factors that most of them we can identify when the patient arrives in our emergency department are Glasgow Coma Scale. The lower, the worse the outcome. Higher age, a large bleeding volume or involvement of the ventricle in the bleeding are predictors of poor outcome in ICH. But even in patients that survived an anticoagulation-related intracranial hemorrhage, we have to understand that the majority of those patients will be faced with poor functional outcomes. And the rates are up to 80% for DOACs and vitamin K agonist bleeding survivors that they have brain damage that will remain chronic. Risk factors for recurrent ICH are also to be considered, and they include uncontrolled hypertension, older age, or lobar hemorrhage. The next section, I'd like to discuss evidence for DOAC reversal agents for the management of ICH. Because, as I said, bleeding will occur, bleeding has sequelae and carries a high risk for mortality for these patients. So here is a case study of a DOAC-related ICH. A 76-year-old man presents to the emergency department at 8 in the morning with a suspected ischemic stroke. And this suspicion comes from his neurologic symptoms in the context of being an atrial fibrillation patient. On arrival, he's hypertensive, and his wife explained to the paramedic that her husband is taking a twice-daily anticoagulant tablet, but she's not sure which one it is. But she was sure he didn't take it this morning. So last intake, very likely last evening. So as an emergency physician, what are the steps that need to be taken? Obviously, we need to lower the blood pressure because 190 millimeter mercury systolic blood pressure is way too high in a bleeding patient. But it's also too high in an ischemic stroke patient. We need to verify whether the patient has taken his anticoagulant and what the anticoagulation level is. But then, most importantly, is a rapid CT scan. We need to differentiate between ischemic stroke in an AF patient, undercoagulated, or a patient bleeding from his anticoagulation. That's a different story. The symptoms are similar. The risk profile of the patient is identical, but the CT scan will tell us, is it ischemic and we go for thrombolysis, or is it hemorrhagic stroke and we need to reverse the anticoagulation if there is a lot of anticoagulation activity remaining in the patient. So, what are the important drivers of outcome? As the CT scan will demonstrate in our patient an hemorrhagic stroke, and the lab test will identify a relevant blood level of the DOAC, we have certain things that we need to do rapidly. Control of blood pressure. Lower the blood pressure means decreasing the progression of the hemorrhage. Reversing the anticoagulant effect is on the tablet or on the drug side, the management that hopefully will prevent hematoma expansion. And both factors together hopefully will improve survival and functional outcome of our patients. So if we are slow in lowering the blood pressure, if we are slow in identifying anticoagulation status or the bleeding in the brain as the main problem of the patient, then we contribute by our slowness to mortality and morbidity and poor functional outcomes. That's why nowadays we talk about care bundles. We don't focus on a certain intervention, but it's a bundle of interventions that the patient will benefit from. Rapid anticoagulation reversal within the first hour after admission. Antipyrexia treatment, lowering the systolic blood pressure, and strict glucose control are the four main parts that have been tested in the INTERACT-3 trial as a care bundle to improve the mortality. And compared to usual care, this care bundle strategy resulted in a 14% reduction in poor functional outcomes. The targets are blood pressure around 130 to 140 millimeter mercury systolic. We know that ideally anticoagulant reversal should happen in the first hour, but in real world settings, 90 minutes are more realistic. And those patients, if possible, should be referred to prompt neurosurgical referral if the brain bleed needs surgical treatment. If you look at the mode of action of the anticoagulants in the coagulation cascade, which we discussed before, it makes sense to identify reversal strategies that target the same part of the coagulation cascade as the anticoagulant. So, if we talk about a warfarin patient, we give 4-factor PCC, which contains concentrates of factors 2, 7, 9, and 10. If the patient is a DOAC patient on a factor 10A inhibitor, we provide a factor 10A inhibitor antidote such as andexanet alpha that binds the DOAC and sets free the factor 10A. If the patient is a dabigatran patient, we can use either rosizumab, which is also an antidote specific to dabigatran. It binds dabigatran, it sets free thrombin again, and the coagulation cascade is again fully activated. So when you talk about PCC, it's non-specific because it's not targeting the DOAC, it's simply replacing the DOAC-inhibited coagulation factors. It is also not approved for DOAC reversal, but guidelines tell us we can use it in life-threatening or uncontrolled bleeding situations. The terminal half-life is at least 24 hours, so it's a long action of a PCC. And for the contraindications, this depends really on the PCC type you are using and where you are using it, so your jurisdiction. So please refer for contraindications to your local SNPC. For idarucizumab, as I said before, it's a dabigatran-specific antibody. It's approved for DOAC-related complications such as life-threatening bleeding, uncontrolled bleeding, or emergency surgery or urgent procedures that are needed in a DOAC-treated patients. It is very rapidly acting. Within minutes. It binds dabigatran and sets free thrombin again. Half-life is around 4 to 8 hours. For andexanet alpha, it is specifically binding to apixaban, rivaroxaban, or edoxaban. It is approved to be used for apixaban and rivaroxaban patients at present, and for patients with life-threatening or uncontrolled bleeding. Similar to idarucizumab, the onset of action is very fast. Within minutes, you bind this factor 10A inhibitor and you set free the factor 10A, the native factor 10A. Half-life, again, 4 to 7 hours. What evidence do we have to support the use of reversal strategies in DOAC-related ICH? First of all, for PCC, we do have a meta-analysis of 23 studies involving nearly 1,000 patients with DOAC-related ICH. And these studies included 4-factor PCC. In this meta-analysis of pooled data, the anticoagulation reversal rate was nearly 80% for PCC. When it comes to idarucizumab, we talk about dabigatran-treated patients. The REVERSE-AD trial is a phase 3 trial that compared idarucizumab in patients with uncontrolled bleeding or urgent surgery. You see the anticoagulation reversal rate in these patients was again around 80%. For andexanet alpha, we have a number of studies. Fully published is the ANNEXA 4 trial. In press and presented only as a Congress abstract are the data from the ANNEXA-I study. But both studies have shown that the anticoagulation reversal rate again is around 80%. So we now have talked about the clinical effectiveness of the reversal strategies, but as always, we need to consider side effects of these treatments. And this is difficult to assess in the context of ICH because I pointed out before, mortality associated with ICH is high in itself, and the risk of poor functional outcome or residual sequelae is high. At the same time, the patients treated with a DOAC are at thromboembolic risk from the beginning. So it's very difficult to judge on the safety of a reversal strategy because there's interference of the baseline risk from the bleed or from the patient's risk profile. Furthermore, there are no valid comparative data so far comparing the safety side of PCC strategies and andexanet alpha or idarucizumab. So please, when we discuss the data now, keep in mind that there are standalone data for the components PCC or andexanet alpha or idarucizumab. Having said that, the mortality rate in those 18 studies reporting all-cause mortality after DOAC reversal with PCC was 26%, with a thromboembolic event rate reported at 8%. If you look at the 13 studies that reported the outcome of andexanet alpha-treated patients, all-cause mortality 24%, thromboembolic event rate 14%. For idarucizumab, in 5 studies, an all-cause mortality of 11% with a thromboembolic event rate of 5% were reported. Multiple factors influence the safe and effective use of DOAC reversal agents. First, obviously, comes the management of the bleeding source. If you can control the bleeding by a surgical procedure, for instance, or an intervention endoscopy, it's probably the better strategy to focus on this management to stop the bleeding mechanically rather than go for a reversal strategy, but you might need both. Then we talk about patient monitoring, general hemostatic measures, calcium control, pH control, temperature control. That is important to achieve effective hemostasis also in general terms outside of anticoagulation bleeding. And then you have the more specific approach using PCC or DOAC reversal strategy. Then you have to identify the optimal dose for these patients, and you have to consider the thromboembolic risk related to your intervention, to the reversal agent, but also the thromboembolic risk the patient brings in, because he is on an anticoagulation for a good reason. He is, by definition, a thromboembolic risk patient. And then, obviously, guidelines and guidance statements should be considered and included in your decision-making process as well. Risk reduction is important, as patients with an ICH also have a risk of thrombosis from their morbidity, or from their condition. And if you say this patient has developed an ICH, so let's stop anticoagulation in this patient, you might lower the risk of bleeding, but you will definitely increase the risk of thromboembolism. So it's a balance or counterbalance to be made. Now that we have discussed the available reversal agents, I'd like to point out that there are more agents in clinical development. Siraparantag is a drug that is already in clinical phase 2, and other drugs are in early clinical development. We have summarized the ongoing trials with DOAC reversal agents, including the existing reversal agents such as PCC or andexanet alpha. We did look at idarucizumab, but we could not identify ongoing trials at present. And listed here are also the reports on emerging agents, including siraparantag and other drugs. So for the management of DOAC-related ICH, let's see what the guidelines say. And here are listed some examples for existing guidelines from all over the world. So ASA, AHA, APSC, ACC, ESO guidelines. They are diverse, and please be aware that they might be potentially outdated because, as I pointed out, we have had the report of the ANNEXA-I study only on a congress-based and congress abstract so far, but there will be a full publication expected in the next couple of months. So watch out for those data. But obviously, by definition, those data cannot be part of the guideline statements yet. Still, there are recommendations how to approach a DOAC-related ICH patient. First is discontinue DOAC immediately. That makes sense, and that is consistent across the guidelines. But then the drug that is still in the body needs to be considered. So establish the time since last dose, establish the type of the DOAC, establish the dosage of the last intake. So this gives you a clinical assessment of how likely is it that the patient is still on high concentration of DOAC in the blood. If the drug was taken within the last 2 hours, some guidelines recommend activated charcoal enterally to bind those DOAC proportions that are still in the gut and not in the blood. If the patient is on dabigatran and if a specific reversal agent such as idarucizumab is available in your hospital, this is the way to go according to the guidelines. If the answer is no, idarucizumab is not available, then PCC is the recommended strategy. If the DOAC is apixaban or rivaroxaban, and I would put edoxaban here in bracket because, as I said, as of now, andexanet alpha use is only approved in Japan for edoxaban-treated patients. But if the patient is on one of these factor Xa inhibitors and andexanet alpha is available on your site, then this is the way to go, according to these guidelines. Very consistent recommendation. If you don't have access to andexanet alpha, or if there are contraindications to it, you should consider PCC treatment for the patient. They are consistent in advocating first-line use of andexanet alpha or idarucizumab where available. If you go for a reversal strategy, you need to act fast, because the sooner the patient is being treated with a DOAC reversal, data indicate that you improve the outcome of your patient. The strength of recommendations across guidelines also varies due to a lack of inclusion of recent trials in some older guidelines. And as I pointed out, there will be updated data, subgroup analysis from the ANNEXA-4 study, the original publication of ANNEXA-I, and later on, probably also subgroup analysis for the ANNEXA-I study will especially improve our evidence base for using andexanet alpha in factor Xa inhibitor-treated patients. As I said before, after surviving an intracranial hemorrhage, the patient still is at thromboembolic risk. So a decision has to be made whether to restart anticoagulation, when to restart anticoagulation, which type, which dosage. And again, there are guidelines and guidance statements out there for this decision making, but they are variable. So it is probably a good idea to look out for the most recent guideline or for the guideline that is closest to your jurisdiction where you're working, and identify your local and most updated recommendations on how to treat the patient. Timing, dose, type of anticoagulation really depends on the clinical situation of each patient. And this should be, the decision-making should be done interprofessionally, so multidisciplinary, involving a hematologist or thrombosis hemostasis expert, obviously involving a neurologist, maybe involving also the cardiologist or whoever is in charge of managing the thromboembolic risk of that patient. So usually those patients are complex, and my recommendation is not to do this decision on your own. What you need to do is a risk assessment of the patient. For atrial fibrillation patient, you can use the CHEST score that will give you the risk of stroke if you don't anticoagulate the patient. For VTE patients, there are other predictive scores available showing or indicating the risk of recurrence if you don't anticoagulate. And then you have the tools such as the HAS-BLED and other bleeding risk tools to try to predict the risk of recurrent bleeding in this patient. And this gives you then an indication of how important anticoagulation or not anticoagulation for this specific patient is. Going back to our case study, the CT confirmed ICH in our patient. Apixaban was identified as the anticoagulant, and this was probably derived from the fact that the wife told the ED doctor it's a twice daily tablet, so not a capsule, which could include dabigatran, but a twice daily tablet is the typical dose of Apixaban. The antifactor 10A level was measured, and it was 112 nanogram per ml. So that is really an anticoagulated patient with an ICH on a DOAC. So here a reversal strategy is indicated, and the ED doctor decided to use andexanet alpha at the low dose regimen, which is appropriate in that context. Last intake of Apixaban was on the evening before, and also the factor 10A level, which does not need to be taken into consideration, but if it's available, obviously it's implementing may help with dose finding of andexanet alpha. Blood pressure was immediately lowered because, again, in the care bundle, that was important to improve the outcome of the patient. And after 7 days, he could be discharged to neuro rehab for the management of his residual impairments. The decision whether to restart anticoagulation and when to do that, obviously, then needs to be made in the neuro rehab setting or thereafter. My summary is, although DOACs are generally associated with a low risk of bleeding rates and in the context of bleeding with a better outcome compared to warfarin bleeding, and this is the reason why DOACs are increasingly used in preference to warfarin treatment, DOACs are also associated with a risk of ICH and other major bleedings. This is because the patient is old, fragile, comorbid. Some patients will bleed also in the era of DOAC. For this clinical situation, and especially for intracranial hemorrhage patients, reversal strategies are available that include non-specific approaches such as PCC, but also specific reversal agents such as idarucizumab for dabigatran treated patients or andexanet alpha for factor 10A inhibitor treated patients. These drugs are highly effective and demonstrate an acceptable safety profile within the context of the clinical situation that is driven by a high mortality related to intracranial hemorrhage and a higher thromboembolic risk related to the patient population treated with a DOAC. Around the world, guidelines available that agree on the use of specific reversal agents, and they prefer the use of either racizumab or andexanet alpha over PCC as first-line treatments when available, and putting PCC in the place of a backup option. Thank you for your attention. I hope you have found this to be a useful learning experience on DOAC-ICH. Thank you.